Thank you for listening to the national award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the June 2019 edition of PRS Journal Club podcast. I'm Raj Parikh, PRS Resident Ambassador from Washington University in St. Louis, and I'm joined by my co-resident ambassadors, Lily Mundy from Duke University and Kyle Sanniec from UT Southwestern. Today we have the honor of being joined by Dr. Paul Cederna, the Robert Oneal Professor of Plastic Surgery, Chief of the Section of Plastic Surgery, and Professor in the Department of Biomedical Engineering at the University of Michigan. Thank you so much for joining us, Dr. Cederna, for this PRS Journal Club podcast.
Yeah, thanks for having me. I'm looking forward to the discussion.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we will be discussing today is Evolution of the Surgical Technique for Breast in a Day, Direct-to-Implant Breast Reconstruction, Transitioning from Dual Plane to Prepectoral Implant Placement. This article is from Dr. Antony and her group at Rush University in Chicago. In this article, the authors present their experience with direct-to-implant breast reconstruction in the prepectoral plane compared to the typical dual plane approach for breast reconstruction patients. This was a retrospective review of a prospectively maintained database, and the time occurred from November 2014 to March 2018. The authors' goals were to understand postoperative complications, aesthetic outcomes, postoperative pain, and length of stay in direct-to-implant reconstructions, and to identify differences in subcohorts. This article was driven by the evolution of direct-to-implant technology and technique from dual plane to the prepectoral implant placement, which is a recent national trend. In this series, the authors present 134 direct-to-implant reconstructions that were performed in 81 women. Of these, 42% were the dual plane traditional approach and 57% were in the prepectoral plane or above the muscle. The data collection was only limited to patients who had more than a year of follow-up, so there was some level of long-term follow-up present. They looked at total complications, which in this series were low, 8% overall, and they looked at the incidence of complications in the prepec group compared to the dual plane group, and this was lower in the prepec group with only a 2% complication rate or 1 complication compared to 7 complications or a 12% rate. The two cohorts were very similar in the incidence of reoperation for aesthetic revision, and their pain scores were not significantly different, and their length of stay was also not significantly different. They evaluated aesthetic outcomes by having the subjective panel of surgeons who were blinded to the operation itself, and they evaluated it using a rating scale. There were no patient-reported outcomes reported in this series. Ultimately, the authors conclude that direct-to-implant reconstruction has a low incidence of postoperative complications, and that transition to the prepectoral plane and that technique has not resulted in the increase in complications, has not changed aesthetic results, and has not increased the number of revisional procedures. They argue that prepectoral reconstruction in properly selected patients is a viable option, and it eliminates the potential for an animation deformity, and it can potentially enhance aesthetic results as well. So with that said, I really wanted to get into the discussion of this article. The reason I picked this article is because I thought it was interesting as there is this national trends toward more prepectoral breast reconstruction as well as direct-to-implant reconstruction. Certainly at our institution, we're probably doing now 75 to 80% prepectoral breast reconstruction, but that includes tissue expanders and direct-to-implants. But a lot of those are direct-to-implants when feasible. I think part of this also reflects the national trend towards more contralateral prophylactic mastectomies when patients have nipple-sparing mastectomies and therefore are candidates for the direct-to-implant technique, depending on their body mass index and other risk factors. So Dr. Cederna, I wanted to get your thoughts overall on this study, and then specifically at Michigan, what percentage of your prosthetic breast reconstructions have shifted towards being prepectoral and direct-to-implant compared to the traditional two-stage tissue expander dual plane approach where the inferior sling was an alloderm or just done completely submuscular?
You know, there are a ton of trends in plastic surgery, and plastic surgeons in general are incredibly creative individuals that think constantly about how to improve their outcomes from the way that they were doing things in the past to ways that they think they can do it in the future to not only reduce complication rates, but improve aesthetic outcomes, improve patient satisfaction with the reconstruction they perform. So one of those items now is prepectoral placement of alloplastic material of some variety or another, whether it's prepectoral placement of a tissue expander in a two-stage reconstruction or direct to implant in a prepectoral position. And so this article is trying to get at some of the questions that concern people the most. And when we always considered where we should put an implant at the time of reconstruction, we're thinking about, we have these mastectomy flaps. Sometimes they're thicker, sometimes they're thinner, sometimes the blood supply is better, sometimes it's worse. Sometimes in the process of doing the mastectomy, we're looking at bare dermis on the other side, and we're wondering if the flaps are healthy enough at all for an implant or for a tissue expander or for a reconstruction at all. And so, we always thought, well, gosh, if we put it underneath the muscle, we have a much better chance of having a successful reconstruction. We reduce our risk. We have healthy, living, breathing, viable muscle there to protect that tissue expander or implant from the outside world, and overall we just feel safer that way. But now with the advent of ADM-based reconstructions, whether it's ADM for a submuscular placed tissue expander implant of some variety, or it's ADM to be used in a prepectoral position, it has now added a lot of opportunities for patients. And primarily when we think about it, we think, well, gosh, if we're not going underneath the muscle, patients probably hurt less. If patients hurt less, they're in the hospital less. If they're in the hospital less, they get home sooner, they get back to work sooner, and overall they're more satisfied with their reconstruction. Interestingly, in this study, we didn't actually see any of those things, which is the thing that's probably most interesting to me is all the things that I thought would be the biggest benefits of prepectoral reconstruction we actually didn't see. But at the same time, we found something that was a bit surprising, and that is that the cosmetic outcomes were actually a little better. And once again, we've always thought, well, the more tissue we have between the implant and the outside world, the more natural the appearing breast will be, and ultimately the better the aesthetic outcome will be. But once again, we didn't see this in this article either. So I think across the board, I think this article really makes us think a little bit more about what are the benefits from this operation and where are we going to get the most bang for our buck when we're doing prepectoral, either direct-to-implant or tissue expander-based reconstruction. So I think at the University of Michigan, we are sort of in line with the rest of the country. We're doing a lot of direct-to-implants. We're doing a lot of prepectoral reconstructions. And even places that are more conservative than others, they too are moving in this direction. And so I think this is an exciting new area. We're going to have to see how things turn out long term. But the most important thing that you said in your summary of the article is in the properly selected patients, this is a great form of reconstruction. And so I think, in the coming years, we're really going to be figuring out who those patients are. What are those appropriately selected patients for direct-to-implant, and what are those appropriately selected patients for prepectoral reconstruction?
Yes, I think those are excellent points. I also found it very interesting, like you mentioned, that some of the things that we thought would be significant, such as perioperative pain, were not in this study. And I wonder if that's because most centers have now implemented some form of enhanced recovery protocols or utilizing adjunct techniques such as nerve blocks, that it's hard to differentiate between a pain score of, say, 2 or 3 and a pain score of 3 or 4, at least to have it be statistically significant. The amount of patients you'd probably need in the study for that to tease it out would probably be a lot higher than they had in this study. And I do think the proper selection of the patients is really critical. If you look at their table 2, the amount of patients that got radiation in the prepectoral group was 1 patient or 2% of the entire population. I certainly think if you look nationally, those numbers of patients who are getting implant-based prepectoral reconstruction with radiation would be much higher. And I think that's always the concern as these new techniques become adopted with widespread adoption, is that people kind of forget some of those inclusion and exclusion criteria and start to widespread apply them to maybe patients who aren't the best candidates. So I think that's something that certainly we should all be cognizant of going forward. One of the things that I did want to get your thoughts on was the lack of patient-reported outcomes in this study. And do you feel that it's necessary in today's age to include patient-reported outcomes when they are validated scales, such as the breast-Q, and these types of studies going forward, so we can really look at things such as quality of recovery and outcomes from the patient's perspective with new techniques?
That's obviously a really good point. And there's this progression of scientific investigation that occurs. So when you have no information about something, the best information you can possibly provide is a case series. We did 10 of these things and this is what we got. Sort of basically one of these papers that says what I did on my summer vacation. But then once you have that paper out, then you know a little bit more about it. And then maybe you take a larger case series and you do a retrospective review. And that retrospective review may expose a few things here or there, but retrospective reviews are in general a highly select group of patients that went down a certain treatment path for whatever reason based upon surgeon preference. But that also gives incredibly valuable information, and that information then can be used to design larger prospective-based studies. And then when you have these larger prospective-based studies, you can really start teasing apart the critical elements that you need to know more about based upon what you determined with the previous studies. And when you have some data collected, you can then also begin to do your power calculations. And I know that you mentioned that previously about the pain and did we have sufficient power to be able to detect differences in the various groups in pain, particularly when we consider new advanced pain treatment algorithms to sort of improve patient pain control postoperatively. But you can then start teasing those apart in the prospective studies as well. And then once you have that prospective information, and then that tells you how people perform at a single institution or a single surgeon and how they perform. But once you have that information, now you can do your multi-center prospective randomized trial, which really allows you to get the best quality information possible to really detect the small differences between the various treatment groups. Now, the important thing also to keep in mind is statistically significant differences don't necessarily imply clinically significant differences. So even if I have 20,000 patients per group, and my pain study in one group it's 2.1 and the other group it's 2.7, probably not an important difference, even though it may be statistically significant, because for those patients, they basically have the same amount of pain. However, that information is really valuable when we look at other important details, like if we really want to tease apart, should those patients who previously have had radiation therapy be undergoing direct-to-implant at all? Or if they're undergoing direct-to-implant, should they be doing it in a prepectoral space or in a subpectoral space? And so all these questions then you can tease apart. But ultimately, at the end of the day, what we as surgeons are satisfied with isn't what's important. Really, the only thing that's important is how satisfied are the patients with their reconstruction, and are we actually doing those things that will make them have the highest level of satisfaction with their reconstruction following treatment for their cancer.
Thank you. Yes, I think those are excellent points. Kyle and Lily, did you have any thoughts on this article or on what Dr. Cederna has mentioned so far?
I found the study really interesting because a lot of the studies that we've had about direct-to-implant haven't necessarily focused on the location of the implant placement in such a large study with large follow-up, but even though they have a good number of patients, they're still really just allowing us to outline the questions that we want further answered. And as we mentioned, I think patient-reported outcomes are so important in this patient population, and we do have things like the breast Q that have really changed how we're looking at breast research. That would be great to use, going forward in more in-depth studies of this. And I thought it was interesting how they chose the people to make the clinical assessment of the outcomes and how they chose the general surgeon, the plastic surgeon, a radiologist, and a medical oncologist. These are obviously medical providers that are interfacing with these patients frequently, but this is not necessarily like a substitute for things like the breast Q data. But again, I thought it was a great article, and it's really nice way to start thinking about some of the thoughts that, we anecdotally had assumed patients would have higher rates of, fat grafting or revisions for pre-pec implant placement and things like that.
I think the thing that's interesting in breast surgery now, the quality of the research that we're performing is really incredible. The fact that we have such great validated survey instruments to assess patient-reported outcomes is so important. And if we look at the papers that were being published on breast reconstruction 20 years ago, they really were papers that just said outcomes from my last 75 whatevers. And now, we all expect them to be using validated survey instruments. And so this prepectoral form of reconstruction in combination with direct-to-implant, this is an entirely new area. This paper is a really, really valuable paper to us because it really asks us to ask additional questions that we didn't think of asking before, and it really is going to help us design the next series of studies to really get at this a little bit more carefully. So I think this is a really, really good paper. I think it's really valuable, and I think the level of science that we're performing in breast surgery is substantially better than the level of science we're performing in a number of different areas in plastic surgery. And I wish the rest of plastic surgery caught up to where breast surgery is now, because this is good science and this is well done.
Yes, I completely agree. I think the quality of the studies coming out in breast reconstruction specifically are just so high. I mean, I think every time a new technique is developed, I think studies like this are valuable, even though they're a single center retrospective study, because it does identify future directions, as well as kind of what the personal experience is as we get started with some of these techniques. So I did find the article very valuable in that regard. I think with that, we will end the discussion of this article. Thank you everyone for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also remember to tune into the other 2 articles that we will be discussing at this month's podcast. Finally, please join us for a monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not already done so. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Cederna, for joining us today.
My pleasure. Thanks for having me.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.